Srinivas Kambhampati for his great effort over more than 6 months to complete this
Recording
course
in
and
progress.
this collaboration between India and Egypt. Tonight we have a very special guest, Dr. Karthik Vishwanathan from India. We'll speak about osteoporotic fractures. And Dr. Mahmoud Kandil from Egypt will speak about fracture without significant trauma. First presentation will be by Dr. Karthik, and Dr. Srinivas will be the moderator of this presentation. Please, sir.
Thank you very much, sir. Good evening, everybody. Please unshare the screen, Karthik.
Sure.
Thank you again, Professor El-ashhab. Before I introduce the speaker, let me just say a few words about the last 7 months of moderating these talks. Actually, we come to the conclusion of this series of Egypt and Indian collaboration. It has been an amazing journey of learning and friendship. Wonderful experience with Professor El-ashhab, who is full of energy, and also a pleasure to listen to some experienced Egyptian surgeons. I would like to thank all the speakers from India who agreed to speak in spite of their busy schedules. And thanks also to Indian Orthopedic Association for their support. And these sessions would be very useful for both Indian and Egyptian surgeons alike. And special thanks to OrthoTV for their smooth and seamless work with the broadcasting to reach hundreds of surgeons worldwide. And coming to the speaker for today, I am pleased to introduce you to Professor Karthik Vishwanathan. He's a good friend of mine, an excellent statistician and an associate editor of the Indian Journal of Orthopedic. Let me just share. So he is Professor. So he's professor at Parul University of Medical Sciences and Research in Vadodara in Gujarat state of India, and honorary senior lecturer for MCH Orthopaedic, Edge Hill University and Wrightington Hospital, UK. He's a fellow of the Faculty of Surgical Trainers of Royal College of Surgeons of Edinburgh. He's also assistant editor for JCOT and associate editor for Journal of Orthopaedics, Indian Journal of Orthopedics, and Journal of Arthroscopy and Joint Surgery, and editorial board member for Apollo Medicine. He is a principal investigator for Indian Council of Medical Research project on venous thromboembolism, and completed 2 ICMR-funded projects before. And he has numerous publications in PubMed index journals and Scopus index journals, multiple presentations in international and national conferences, and he's trained in India, and further specialization was done in the UK. He's a tutor for Edinburgh Surgical Sciences Qualification University of Edinburgh, and trains doctors for MRCS, and tutor for MCH Orthopedics as well. His area of interest includes arthroplasty, arthroscopy, spine, hands, foot and ankle, trauma, and pediatric orthopedics. Thank you very much for accepting the invite, Karthik. I'll just stop my share. The topic for him today will be on osteoporotic fractures. Thank you very much. Please go ahead.
So at the outset, I apologize because I have a sore throat, so I may not be able to talk very loudly. But thanks, Dr. Srinivas and Prof. Mohamed El-ashhab for giving an opportunity to share my experience and learn something new. We are constantly learning, and I would like to share my views on osteoporotic fractures. So the full screen is visible, right, Shri? No issues. Okay, right. So the proportion of geriatric population increases worldwide, it is estimated that by the World Health Organization, the one of the targets where they have named 2020, the present decade, as the decade of healthy aging, and the United Nations, one of the targets by 2030 is to have, the agenda is for sustainable development, mainly focusing on musculoskeletal health. So this is the typical fracture scenario. This is the age. So first usual fracture is either a wrist fracture or a proximal humerus fracture, followed by a spine fracture. And as the age increases, after the age of 80 years, the incidence of hip fracture increases considerably. So the osteoporotic fracture or fragility fracture would be termed as any fracture which is sustained when somebody falls from a standing height or a low energy or a trivial trauma. So osteoporosis, this is technically a pathological fracture. The most common cause is osteoporosis. So what are the goals for treatment of these fragility fractures? The aim is to restore function, early mobilize these patients, because if we don't do early mobilization, the risks of prolonged recumbency such as urinary tract infection, deep vein thrombosis, pulmonary embolism, urinary tract infection increases manifold. And also the last point is the key point, which is to prevent subsequent fractures. If you see somebody with an upper limb fracture, you want to prevent a spine fracture, or still worse, a hip fracture. So that would be the goals of treatment. So coming to the key biomechanical aspects, osteoporosis is defined as a reduced bone mineral density. It tends to affect trabecular bone more than cortical bone. Because it affects the spongy bone or the trabecular bone, the holding power of the screw, which is proportionate to the bone mass, decreases. Hence, the risk of failure of fixation with traditional methods is very high in osteoporosis. Though, having said that, the healing rate is supposed to be technically unaltered. The most common methods of failure of the traditional implants is either a cutout of the screw or an implant cutout. So, two main factors which we are dealing in osteoporosis is not only a reduction in the bone mass, but also some of the fractures have extreme comminution. So, if the fixation has not happened properly, the consequences are going to be a loss of reduction, a malunion, a delayed union, and we as surgeons have. So one is a polymethyl methacrylate bone cement, which is commonly used, but it acts technically as a grout. So it is not osteoconductive. It is just a space filler agent, but is cheap and easy to use even in resource limited settings. So to increase the holding power, mainly in trabecular bone, the cement can be injected and then you can pass screws to increase the holding power of the screw. We also have calcium sulfate pellets, calcium phosphate. Both calcium sulfate and calcium phosphate are osteoconductive. And they also, calcium phosphate is a bit better biomechanically compared to calcium sulfate, only because it tends to even stay during the remodeling process till all the remodeling is complete. It stays there. Both sulfate and phosphate compounds are resorbable, so they are not going to be there forever. Having said that, if you have to remove a screw which has been passed in PMMA bone cement, technically taking it off, if at all, if it is required in future, becomes difficult once the screw gets fixed. Other advances include hydroxyapatite coated screws or a hydroxyapatite coated shank pins. It's mainly for external fixators. They can be used. Bisphosphonate coated screws are also being researched and they may also find their way in the near future. So these are few examples of vertebroplasty and kyphoplasty where osteoporotic spine, the cement has been injected to regain the height of the vertebra. It also can be used in proximal humerus fractures to elevate depressed bone fragments and also to improve the screw pull-out strength. Also proximal tibia fracture, where if you elevate and then you either use methacrylate or a calcium phosphate bone pellet. In proximal femur fracture, also cement can be used for augmentation of the screw to increase the holding power of the screw. So coming to common configuration, the first one, which is the unlocked, is the traditional plate, right? The screw does not lock onto the plate. This is the locked screw configuration, where the screw head actually goes and matches with the holes in the plate. Okay, this is best. And then the problem with the lock plate is it does not apply compression at the fracture site. So if you want to reduce the plate to the bone, you better use a combination of both locking and non-locking screws, and these are called as combi plates or hybrid plates. Okay, so these were the traditional plates, and the risk of failure of these are very high on osteoporotic fractures because these are technically load-bearing devices. It relies on the friction between the plate and the bone, and hence that was the weak link. Okay, so though there are various techniques, but since even in resource limited settings, we have locking plates available, they are much better in osteoporotic fractures. They may have some role in diaphyseal fractures and something like when they are used as anti-glide plate, mainly in around ankle fractures and proximal tibia fractures, they can be used. So this is a vertical shear fracture, vertical fracture of the medial malleolus, which has been fixed with a traditional plate, which, this opposes shear forces. Sorry. So, and this is a traditional non-locking plate, and it works very well when it is compressed, even in elderly patients. These are the workhouse of treatment in osteoporotic fractures. It is an advancement because it works on friction between the plate and the screw head. These are angular stable devices. Hence, all the screws which are locked onto the plate, they all work as fixed angle devices. So the uses are going to be mainly in metaphyseal fractures with a lot of comminution, periarticular fracture. This is where these anatomically pre-contoured locking plates have a role. But the limitations are, if it is very, very stiff, if you put in a lot of screws, if it is a stainless steel plate instead of a titanium plate, and if you are putting bicortical screws at the end of those plates, the last screw hole, proximally or distally, the risk of peri-implant failure is there because the osteoporotic bone has got less modulus of elasticity and less stiffness compared to the implant. So it is better to use titanium locking plates if that is available. Also, the locking plates cannot facilitate reduction of the bone to the plate. So you have to the reduction has to be good if you're using only a pure locking plate instead of a hybrid plate. So hybrid plates or combi plates are a combination of both locking and non-locking screws. And you first put a non-locking screw to pull the bone towards the plate, and then you supplement with other locking screws. So better is to use near, far configuration, and these are very ideal for fractures, metaphyseal osteoporotic fractures with comminution. So I'll start with broad principles. So intramedullary nails also are useful, especially as load-bearing devices. They are used mainly for proximal femur fractures as proximal femoral nails. Better to use long ones if the bone is very osteoporotic, or if the patient is short, and short and obese patients, the curvature tends to be high. So you better to use, instead of short nails, which can impinge on the anterior cortex of the femur, better to use a long one. Advances are the proximal femoral nail used to have 2 screws, but now we also have helical blade, and you can also put cement through them. And then if the fixation is dodgy, you can put cement, wait for it to set, and then put the helical blade or 2 screws. You also have the traditional intramedullary interlock nails had 2 distal locking, but now you have option for doing both anteroposterior and lateral to medial side locking screws in multiple planes. So coming to specific fractures, so in proximal humerus fracture, if it is a stable and reducible 2-part fracture, percutaneous pinning is an option. However, if it's 2-part fracture and there is good proximal bone stock, you can use a proximal humeral nail. While 2-part, 3-part, 4-part unstable fractures, the workhouse is a Philos plate or a proximal humerus locking anatomical plate. If it is a head split fracture, depending on what is available, either you can use a reverse shoulder or a hemiarthroplasty, depending on what technique you're comfortable with. Both are reasonable options. Few examples: 2-part fracture stabilized with a proximal humeral interlock nail, antegrade nail. But in this, it is important to repair the rotator cuff. If you have made a split, the repair is very important. So this is a Philos plate, again 2-part fracture, stabilized. The most important screw is the medial calcar screw. You can't put it too high. If it is too high, it will impinge on the acromion. If it is too low, this screw, the calcar support screw, will not support the calcar and it predisposes to varus collapse. This is an example of extreme medial comminution where a fibular graft can be put as a strut, and then you can put this Philos plate on it so that it prevents the varus collapse. Long head split fracture, again used wiring. These are not my figures, but these have been from articles. And reverse shoulder seems to be the implant of the prosthesis or the procedure of choice, especially in the hand of experienced surgeons. Excuse me. Next, humeral shaft fractures. Traditionally, conservative treatment is not bad. Intramedullary nail, have we put it, but it is antegrade nail has come out of flavor because of various problems of impingement and shoulder problems. Locking plate or plating is the gold standard for fixing. And because locking plate rather than traditional plate, because the risk of failure of fixation is high in these type of fractures. One example, again, a periarticular fracture. You put a periarticular plate and then locking plate, and that suffices. Distal humerus fracture. If it is an extra-articular undisplaced fracture, elderly patient with comorbidities, conservative treatment does work well. The fracture does unite. So not all fractures need an operation. So that's why I put these slides. Again, the choice of treatment depends on the age of the patient, quality, the personality of the fracture, as has been taught to us. Low transcondylar type of fracture, intercondylar fracture, stabilized with parallel plates, anatomical plates, both medial and lateral column, or 180-degree plates. This is a distal humerus fracture in an elderly patient with extreme comminution of the articular bag. It's like a bag of bones. And in patients with low demand, elderly patients, retired lifestyle, you can use, you use the cemented total elbow replacement. That also works well for in these sort of patients. If it is a multifragmentary olecranon fracture, instead of tension band wiring where there is a chance of collapse, better to use a locking anatomical olecranon plate. It gives good result. Distal radius fracture, usually the first fracture to happen. Conservative treatment, even if it is malunited, is not that bad in extra-articular fractures because the results are amazing. So we cannot completely discard conservative treatment. It has a role. The latest ones which are available are anatomical volar plates for distal radius. Both fixed angle and variable angle ones are the traditional workhorses, especially in elderly patients with intra-articular extensions. So fractures with intra-articular fractures, volar button, dorsal button fractures can be fixed well with volar plate, locking plate. These are images of a intramedullary nail passed from distal to proximal, a retrograde nail. These have roles in extra-articular fracture. In intra-articular fractures and fractures where you don't even think that you may have good screw hold, the fracture is very distal. You can use a joint spanning, usually a 13 or a 14 hole plate, and you leave it for about 2 months or so, then take it off. It gives, it aligns and it works as an internal fixator. These are also these are acceptable options in geriatric patients. So coming on to the lower limb, for acetabular fractures, you can do with a Stoppa's approach. If there is a fracture in fracture dislocation and a medial wall deficit, better to fix it with buttress plate. Other option, which is gaining momentum, is combined internal fixation and total hip replacement in the same sitting. I don't do this, right? I prefer to do ORIF and followed by a daily THR. Results are almost identical. The only problem is in geriatric age, you don't want to keep them in bed for a long time, but you do whatever works well in your hands. Okay. For neck of femur, this is the only slide. For undisplaced fracture, multiple cannulated screws or a 2-hole DHS with derotation. If it is a displaced neck of femur fracture, because the risk of non-union and failure of fixation is high, better to go for total hip replacement if the patient is very mobile before the fall, or to go for a hemi-arthroplasty if the patient has multiple comorbidities or was using walking aids before the fall. So hemi and total are reasonable accepted options. So this is one patient with a displaced neck of femur having a hybrid type of THR. So for intertrochanteric fractures, again, common osteoporotic fracture. If it is a stable fracture pattern, we use a sliding hip screw or a dynamic hip screw. If it is an unstable fracture, such as a reverse oblique comminuted 4-part fracture or fracture with deficient lateral wall, you'd usually, or a subtrochanteric fracture, you'd go for a proximal femoral nail or a cephalomedullary nail. That is the standard. There is a DHS, 4-hole DHS. Okay, the fracture has to be well reduced. Again, the key is reduction of fracture. If you're doing a DHS, important to have the tip apex distance less than 25 millimeter on both views. Okay, but even aiming for center and center on both the quadrants or a posterior inferior quadrant, the second best acceptable. We have to avoid the antero-superior quadrant. We don't do DHS in a reverse oblique because the chances of failure is very, very high. So this was DHS done in a reverse oblique and it failed. If the lateral wall is deficient or comminuted, the chances of collapse and cutout is very, very high. Again, a proximal femoral nail type of device is much better in these type of fractures. So this is a proximal femoral nail anti-rotation PFNA done for a 3-part fracture. For a 3-part intertrochanteric fracture, a short nail or a standard nail is okay. But for a reverse oblique or a subtroch, better to go for a long nail. Again, this is becoming more and more relevant as bisphosphonate use increases. Bisphosphonate use also gives rise to sort of a stress fracture starting on the lateral side or the tension side, which propagates medially. It shows as the excuse me. It shows as a thickening of the cortex on the lateral side. So that is very important to catch it and stop the bisphosphonates if the patient is already on. If that is already started, better to do a prophylactic nailing even before it breaks, because it eventually breaks. Right? So if it's a distal femur fracture, again, common pattern. If it is extra-articular fracture with good distal bone left, then you do a retrograde distal femoral nail. If it is an intra-articular fracture, which is most of the times, then you do, or a periprosthetic or a peritichial fracture, then you better to do a plating, a distal femoral locking plate. If it is a non-union or a revision case, then the options are to use previously we used to use blade plate. That also is a good device. But again, surgeon has to be trained before they can use that. The other one which is being used is a combination of a nail, a distal femoral nail and a plate. Intramedullary and extramedullary fixation. It seems to be helping in revision cases, failure of fixation cases. If it is a very distal fragment, short fragment with extreme combination, either you can use dual plate, a combination of a nail and a plate. And in some centers, they also do primary TKR in these sort of elderly patients with very low demand. So we have to use something like a hinged total knee, because the collateral ligaments technically, because if they're attached to the bone, they are incompetent. So the traditional TKR will not work. You'll use a hinged prosthesis. Few examples. So multiplanar distal femoral nail in different planes. Okay. A periprosthetic fracture. Okay. Treated if it's if the box is not there. So this is a CR prosthesis. You can get good reduction and you can use a multiplanar distal retrograde distal femoral nail. So this is a periprosthetic fracture of a THR, Vancouver C. Okay, and then we can use a locking plate, a lateral locking plate, which seems to be the workhouse sort of a device for these type of fractures. So in very low fractures, right, you can use dual plates, both medial and lateral plates, okay, to fix it, along with some bone grafts also. Even an extreme combination, better to put some bone grafts or bone graft substitute. Okay. So this is a low transcondylar fracture, again, CR. So you can use both. It allows you to use a retrograde nail. You can use a couple of blocking screws to make sure this is in the center, and then you can put a plate on top as well. So this is also an option. In ankle fractures, traditionally we used to use either a DCP or a 1/3 tubular. The chances of failure were high. So now we have the choice to use a variable angle locking plate. So that can be used. That is one option. The other option is using stacked plates, which are in two different planes. So this is stacked plating, on the fibula. Sorry. And two different 90 configuration for fibula. So the screw purchase has to be very good in these type of funds. So coming on to medical management. So the assessment is done by a FRAX tool. Okay, it was developed by the University of Sheffield. And then the DEXA scan. So it's usually a combination of a FRAX tool or a fracture assessment, risk assessment tool for osteoporotic fracture, or use DEXA scan. So if the T-score is between less than -1 standard deviation, it is normal. If it is between -1 and 2.5, that is called as osteopenia. If it is less than 2.5, then that is called as osteoporosis. And if there is already an insufficiency fracture with less than 2.5 bone densitometry, or less than 2.5 standard deviation, that is called a severe osteoporosis. So if the patient it's very important to medically manage them. The pharmacological treatment is equally important. For any patient who has had a hip fracture or vertebral fracture, they need to go on this. This is worth auditing as to how many patients really go on to post-osteoporotic treatment with this. If it is osteoporosis on a DEXA scan less than 2.5 as per DEXA scan, then also the patient has to be on treatment. If it is osteopenia, but with a high risk factor, the 10-year probability on a FRAX score is more than 20%, then that patient should be on treatment. So this is an algorithm. Again, taken from an article from the orthopedic clinics. Okay. So again, each case, like if it's low risk on fracts and there is the bone mineral density is normal, then you would not treat. Rest of them you would treat. Again, depending on. So because being a surgeon, I concentrate mainly on operative treatment, but these are all the options. Most of them are still available in India. Okay. So I would like to say that, the Indian Orthopedic Association has taken a big step this year. Like, we are releasing a yearbook of osteoporosis. We are surveying the current practice of the members of orthopedic surgeons of India. We are also undertaking various awareness campaigns. So these are all, steps in the right direction. So in conclusion, fracture may be the first time when the patient visits because it's like an iceberg condition. It's asymptomatic. So patient will never know that they have osteoporosis till they have the fracture. Because the fixation is challenging because traditional methods do fail. Hence, with advancement, we have got bone substitutes, augmentation techniques, locking plates. So that has revolutionized treatment. And it is here to stay. So it will be a combination of these, right? So it's a welcome step, the collaboration between Indian Orthopedic Association and Egyptian Orthopedic Association, a comradeship, so that we learn from each other, so that patients have a better quality of life and we provide better patient care as clinicians. So thank you once again, Dr. Srinivas and Prof. El-ashhab. Thanks for giving the opportunity.
Thank you so much, sir. And thank you for this very, very representative slide about the cooperation between Egypt and India. I would like to thank all our dear Indian speakers and all our dear Egyptian speakers for being for their contribution in this very fruitful course. Thank you so much, sir. Thank you. Dr. Srinivas, you are the moderator with Dr. Karthik. Please, sir.
Thank you, sir. Thank you very much, Karthik, for the excellent talk despite a bad throat. I think there are a couple of questions from the delegates here. Before that, I just want to ask, when do you start the pharmacological management for osteoporosis? Once they have sustained an osteoporotic fracture, the typical locations of fracture with an elderly patient, postmenopausal, a couple of decades or so, they don't need to have DEXA scans, especially in areas where the resources are challenged. So how do you decide on starting pharmacological management, and when exactly after the surgery do you start pharmacological management?
Secretary, so though ours is a university hospital, we still don't have a DEXA scan here. So, once the patient has got admitted with either a distal radius fracture, anybody who's more than 60 years and has had a trivial trauma and osteoporosis, looking at x-rays, that it's osteoporosis, I'll straight away start them, basically on calcium and vitamin D before I discharge them. But I tend to start bisphosphonates probably after a month. I'm a bit reluctant initially, but having said that, depending on patient, because that is the cheapest one, because most of these hospitals, they have to provide all this under the Prime Minister's, the medical insurance. Everything has to be within that budget. So, the implant has to be within that budget. So, and when the patient gets discharged, everything has to be provided to the patient. So the bisphosphonates, mainly the alendronate, is the one which comes cheaper. Rest of the parathormone and calcitonin are very costly. So probably I will keep it for later, but not at the time of discharge. So distal radius, proximal humerus, and and spine fractures, which I see in OPD, they all go on treatment for osteoporosis.
And is your loading strategy after surgery different from the non-osteoporotic fractures?
No, I follow the same.
Same. Okay. We have a couple of questions from delegates. The difference between one from the name is not clear actually. The question is different fracture and stress fracture.
So, right, it's a good question. So, a stress fracture. Stress fracture will happen because of repetitive microtrauma on a normal bone, while an osteoporotic fracture or a pathological fracture will happen on an abnormal bone, even with trivial trauma or no trauma at all. So, a common example of a stress fracture would be something like a newly recruited soldier or a policeman who is subjected to unaccustomed exertion, and that is when they sustain something called as a march fracture. So a normal bone, and repetitive micro trauma over a period of time, that is stress fracture.
Another question is, please, I'm not sure what exactly it is, but highlight for bisphosphonate coated screws and its superiority over the use of cement for perfect fixation.
Right. So the evidence is pretty much. I have not used bisphosphonate coated screws because this is still under research things, and it will be an area of research. I would, because cost wise, the one which is available is a methyl methacrylate, and that is not that costly. So I would always use that to supplement. If I do a DHS or a proximal femoral nail, I feel the fixation is not, the purchase, the screw holding power is not good. I'll take it off. Cement is there on the shelf. I will put the cement and then I will put the screw in. So in my experience, I don't have experience of using bisphosphonate coated screws, but this is still an area of research, and probably the future will tell us.
Okay. Professor El-ashhab.
Yes, sir. Please, I want to ask you a question, sir. In some cases, with medullary shaft fractures and long bones, you find that the patient, especially in females, is very osteoporotic. So if I fix it with intramedullary nail, the largest diameter of the nail is not enough for fixation, even with locking screws. So do you prefer in such a case to use a combined intramedullary nailing with an extramedullary nailing in the form of locked plate?
Yeah. So I would, in those cases, preoperative planning, if I feel that, the canal is wide, because the widest canal, the nail that is available to us is size 12. And many times the canal is pretty wide, and you put a nail and you don't get primary fixation. This thing, I will always have a proximal femoral locking plate available. And when I feel that this is dubious and it's not giving good purchase primary stability because of the nail, and the canal is big, like 13 or 14, and the proximal femoral nail is not going to give good fixation at all. So I will use a locking plate instead in those cases, because I have the luxury of having it on the shelf, which is autoclave. So I'll use that.
Yes, sir. Thank you, sir.
And use of sutures in especially for proximal humerus fractures, they are, in my experience, they are quite useful in, especially in two-part or very rarely 3-part fractures. Do you have experience of using them?
So are you saying only sutures by themselves, or in combination with plates?
Just only sutures by themselves.
Right. I haven't, because I usually, when I do 3-part or 4-part, I usually take Ethibond, and the plates that we use, they have holes for KYs through which I pass them and then tie them. So I use a sort of a MIPO type of an approach if possible, and that's what I've seen, like a sort of a limited deltopectoral and then a small incision here, so that I can slide it. So I just open it on a sort of an anterosuperior approach, the Nivasia's anterosuperior approach, and then the Mackenzie one, and then tie it and then put it on. So a periarticular type of plate. So
4-part is too unstable for sutures. I think commonly used for 2-part fractures. 3-part very rarely, actually. We don't have any more questions here. Thank you very much for the session. Excellent discussion. Thanks a lot. We'll move on to the other section.
Thank you.
Session.
Thank you so much, Professor Karthik. Thank you so much, Dr. Srinivas, for this very, very interesting presentation about a very important topic. And now we will move to my second part of the presentation. The next presentation will be offered by Professor Mahmoud Ibrahim, Assistant Professor, Associate Professor of Orthopedic Surgery and Orthopedic Oncology, Benha Faculty of Medicine, and he's actually the head of Orthopedic department in Saudi German Hospital. Professor Mahmoud, what about your voice? Professor Karthik also has a sore throat.
I have a very sore throat, so excuse me for my voice, please.
Not a problem at all.
I also speak from my car as I was an emergency case, so can you excuse me again?
No, not a problem at all. Can you share your screen, please?
Yes, okay. Appear to see your
Yes. Yeah, I can see it. I can see it, Dr. Mahmoud.
Okay. First, it's great to me for this Egyptian-Indian experience. Like to greet my professor, Dr. Mohamed El-ashhab, and Dr. Srinivas. Dr. El-ashhab is my professor. I learned it from him. Still learning so much. He transfers his experience to all second generations. And thank you, Dr. Professor El-ashhab in Faculty of Medicine, to allow me to this opportunity to introduce this. First, our topic is fractures without significant trauma. The fractures without significant trauma can be presented either in normal bone or abnormal bone. If the bone is abnormal, it's called a pathological fracture. If the bone is normal, with is sufficient bone, but with repetitive stresses, it's called stress fracture. Or in insufficient bone, it's called an osteoporotic fracture. So this topic will be on the pathological fracture. The pathological fracture is a fracture through a diseased or abnormal bone, usually resulting from a force insufficient to produce a fracture in a normal bone. Alternatively, the pathological fractures may occur during high energy trauma. So, though high energy trauma does not exclude pathological fractures. These pathological fractures can be classified into several etiologies: tumors, either primary or secondary; metabolic disorders, as the most common is osteoporosis, or infection. Our topic today will be on pathological fractures due to tumors. This will be our topic. Classification of the causes according to the provocating factors is either intrinsic or extrinsic. Intrinsic means pathology inside the bone, as bone tumor or osteogenesis imperfecta. Extrinsic as a previous surgical intervention, as biopsy or radiotherapy. And according to the pattern of the bone invasion, may be systemic or localized. Systemic usually is a correctable disease, as renal osteodystrophy or hyperpara, or diffuse osteoporosis. With uncorrectable disorders as osteogenesis imperfecta or polycytic fibrous dysplasia, postmenopausal osteoporosis, localized as a bone tumors. Classification according to the age. Neonate may be present with neonatal osteopenia, with mineral deficiency, or osteogenesis imperfecta. In infant and young children, usually the bone cyst, rickets, osteomyelitis, or disuse. In children and adolescent, unicameral bone cyst, non-ossifying fibroma, or the malignant bone tumor primary as osteosarcoma or Ewing sarcoma. Adult is metastasis, transient tumor, and fibrous dysplasia, and the geriatric patients are osteoporosis, MITS, and hyperbar. So, as I said before, our topic is concentrated on the pathological fracture due to bone tumors. So we have to put an idea about the tumor stage or behavior. The behavior of the tumors either a primary or secondary, metastatic, and the primary is either benign or malignant. The benign having three behaviors, either latent or active or aggressive. Latent lesion mean it's grow slowly during the normal growth of the individual and then stop, no further growth after the normal growth of the individual. Tendency to heal spontaneously, and the most common latent tumor is non-ossifying fibroma for the bone tumor, and the for soft tissue is lipoma. For the active mean progressive growth with tendency for high recurrence, and as the most common is EBC and neurozoal process. The aggressive lesions are locally aggressive. It look like in imaging as a malignant tumor, but the difference that it don't metastasize. The tumor extends through the capsule into the reactive zone, and the most common aggressive bone tumor is a giant cell tumor. The malignant tumors, the primary malignant tumor can be classified in 1 or 2 or 3. 1 is a staging of 1, means it's low-grade tumor, either intracompartmental or extracompartmental. 2 is high-grade, either intra or extracompartmental, and 3 is any grade with regional or distant metastasis. So the successful management of the pathological fracture to bone tumors requires recognition, diagnosis, and the treatment of the pathological condition. So how to think about fractures with bone tumors? We think about the pathological condition of the underlying lesion. This is very important, as the fracture management may be dramatically altered by the associated pathological conditions. And failure to recognize such condition may be determined either to the patient life or the extent. First, how to suspect pathological fracture. From the history, fracture with normal activity or minimal trauma. Excessive pain at the site of the fracture prior to the injury. It's very important to stress on that point when taking the history of the patient. If they have a pain prior to the injury, as this excessive pain prior to the injury, usually either it's aggressive benign tumor or primary malignant tumor or even metastatic. Patient with known primary malignant disease or metabolic disorders and the history of multiple recent fractures. So the most important point of the history is to concentrate on the pain prior to the injury. Review of system in cases of MITS, GIT symptoms with loss, flank pain, and hematuria. Physical examination, in addition to the standard physical examination, we should direct the evaluation to the possible soft tissue mass at the fracture or evidence of primary disease as lymphadenopathy, surrounding nodules, and so on. The investigations here, we don't take pathological fracture due to tumor is not a simple fracture. Need a couple of investigation according to the underlying pathology, beginning from the X-ray, MRI, CT, bone scan, and PET scan, lab according to the condition, and even lastly is biopsy. So what is the rule of how to think about a case of pathological fracture with underlying tumors? We ask ourselves a simple questions. First, is this lesion single or multiple? Second, where is the location? And the location is in which bone and which part of the bone in the longitudinal or the transverse section of the bone. And lastly is the morphology. Morphology by X-ray from inside to outside, inside the matrix, then the border of the lesion, then the cortex for osteum and soft tissue. These are the questions we asked ourselves in the conventional radiograph. Is the topography of the lesion, borders, type of bone destruction, type of periosteal reaction, and type of the matrix. So our first question, is it single or multiple? Multiple lesions, usually as most commonly is multiple myeloma or MITS. They are the most common in elderly and more than 40 years patients. Other lesions are multiple as histiocytosis, fibrous dysplasia, infection, and hyper. But in elderly, more than 40 years, it's either MITS or multiple myeloma. The location of the lesion, there is specific sites. We said the location, we have to see which bone and which part of the bone. Which bone as parostal osteosarcoma, common in the posterior aspect of the distal femur, adamantinoma osteofibrous dysplasia, specific predilection to the tibia, and the chordoma for the sacrum. Regarding the location, in the longitudinal and in the transverse section. In the longitudinal section, epiphyseal lesions are very common as chondroblastoma, but in young age before puberty, and after puberty, giant cell tumor. They are most common causes of epiphyseal lesions. Clear cell chondrosarcoma are very rare. Most lesions are metaphyseal, and the diaphyseal lesion mostly is Ewing sarcoma at young age. In the adult is lymphoma, fibrous dysplasia, adamantinoma, or histiocytosis. Regarding the location of the lesion in transverse section, lesions with centrally located is a simple bone cyst. We know the simple bone cyst is a central location in chondroma and fibrous dysplasia. Eccentric is ABC, chondromyxoid fibroma, and giant cell tumor. There are cortical lesion as non-ossifying fibroma or juxtacortical lesion as parostal osteosarcoma. This regarding the single or multiple. Second question is the location. And third question, what is the morphology of the lesion in X-ray? So we'll start with the tumor growth. We have a geographic or slow growth with a well-defined border with sclerosis, well-defined border with no sclerosis, ill-defined border, or mouth-eaten and permeative. Mouth-eaten and permeative grade 2 and 3 are specifically for the malignant tumors, while the benign or the aggressive lesions will be 1 or 2 or 3. This shape is for geographic first one, and second for mouth-eaten and permeative. The geographic may be A or B or C, is well-defined with sclerosis or well-defined with no definite sclerosis or ill-defined. This example, first one, is example for centrally located, not central. It is metaphyseal or metaphysio-diaphyseal. It is of slow growth. As we see, it's well-defined with the sclerosis. It's mostly non-ossifying fibroma. Second lesions are for geographic, well-defined, but no sclerosis, mostly metaphyseal or metaphysio-epiphyseal as for giant cell tumor. This is a permeative and mouth-eaten appearance for the highly malignant tumors. Second question in the morphology is the matrix. What is the matrix? Matrix is the intracellular material produced by the mesenchymal cells. It's either osteoid, as bone infarction, or chondroid in most of chondrogenic tumors, or fibrous, it's ground glass. Third one is the cortex. The cortex is either cortical expansion. The cortical expansion usually seen with the benign lesions, either active or aggressive, rarely seen in malignant. Malignant make usually a cortical destruction. Of very importance not to see the cortex from outside. We need to see the cortex from outside, which is in the osteal erosion, as in the osteal scalloping is a very important sign for the malignant tumors. The perosteal reaction, we have a continuous as solid as osteodystioma, linear as EBC and giant cell, multiple lamellar onion peel as in Ewing sarcoma. We have interrupted or complex as Conman triangle, sun ray adhere on end appearance, they appear on osteosarcoma. Lastly is the soft tissue mass. We see in the benign, usually the tumor don't have soft tissue mass as there is a containment of the lesion by cell of perosteal new bone. There are some exceptions as ABC and giant cell tumors, we can see a soft tissue mass in these types of tumors. While in malignant, there is a cortical erosion. This cortical erosion caused a soft tissue mass outside the perosteum, which causing the Codman triangle. So this is a diagram. So the benign lesion is a well-defined, usually well-defined with a sclerotic border, with lack of soft tissue mass, solid perosteal reaction, and geographic bone destruction. On the left side, the malignant lesion is an interrupted perosteal reaction, mouth-eaten or permeative bone destruction with soft tissue mass and wide zone of transition. After doing the X-ray, we have to ask about selfies to reach usual a differential diagnosis from single or multiplicity of the lesion, from the location of the lesion, and from the morphology for the X-ray, we can reach a differential diagnosis. The CT and the MRI usually are for just to more appearance of the characteristic of the lesion and more differentiation, and usually they are for perioperative assessment of the lesion. CT is used for CT-guided biopsy, can evaluate the extent of the lesion, especially the cortex, and in special sites in the complex anatomical structure, scapula pelvis or the sacrum, and assess ossification or calcification. MRI usually is done with contrast to determine the size and extent. The most importance of the MRI is not diagnosis, but is MRI very important in what we call escape lesion. As we see, this is the case of osteosarcoma, bone sarcoma. The satellite lesion mean lesion within the capsule of the tumor, while escape lesion is area outside of the tumor, away from the tumor. And this lesion does not appear usually with X-ray, usually appear with MRI, but of importance, when we ask for MRI in a malignant tumor, we have to ask MRI in the whole bone. And if the lesion of the osteosarcoma in the distal femur, we ask for MRI on the whole femur, from the knee to the hip, for this escape lesion. As this escape lesion is present, and we don't see it on MRI, we can do bone resection for wide resection for the sarcoma, and even after a short time of the surgery, the lesion is recurrent in different areas due to presence of escape lesion. So the detection of the escape lesion with MRI is a very important note. Value of bone scan, usually the bone scan, we don't, in bone scan, the most important is to see the lesion. Is monostotic or polystotic? Is a single or multiple? A single lesion have a differential diagnosis, and multiple has a differential diagnosis, as we mentioned before. But the bone scan, we don't mention, the importance of hot scan or cold scan. Most of the tumors usually are hot, very rare as myeloma or renal cell carcinoma are cold, but most of the malignant tumors and even the benign tumors as osteoidostoma have hot scan. So the importance of the scan is not to see it's cold or hot lesion, and the importance of the scan to see it's single or multiple lesions. PET scan, the positron emission tomography, it depends on the FDG, low fluoride oxyglucose. This PET scan is very important. It's sometimes a combination between bone scan and MRI or CT. Usually it's important, very important in diagnosis of the lesion. As we know that the bone scan can tell us this lesion is benign or malignant, as it's hot in most of the malignant and hot in benign lesions. So PET scan is very important to suggest why this lesion is benign or malignant through SUV, and even can send us for the metastasis. Very important in the staging, very important in response of the tumor for radiotherapy, and very important in suspected recurrence and restaging if the disease tumor is recurrent. After we do the lab and the radiology, very important to do biopsy of the tumor. Biopsy of the musculoskeletal tumors is important or indicated usually in two situations. First situation is suspected malignancy. Either the tumor is primary malignant tumor or aggressive benign tumor. In criteria that appear on X-ray or CT or MRI with highly aggressive tumor, so the biopsy is indicated. This is the first situation. Second situation is a patient who is known as a primary tumor, the renal cell carcinoma or a lung or liver carcinoma, whatever, and has metastasis. But the metastasis is a single. We have a single mets located on the distal femur, in the proximal humerus, but in single. On CT, on bone scan, and on the PET scan is a single mets. So single mets never to be a single mets without a biopsy, as it may be a primary malignant tumor, and we will see the different types of treatment for this. The importance of biopsy, there is risk of improper biopsy at the tract should be excised with the 50% of the tumor with the definitive surgery. And the patients that undergo poorly performed biopsy may require amputation. So our recommendations is the surgeon or the institute, if not equipped to perform accurate diagnostic studies or even the definitive surgery, the patient should be referred to specialized treating center for the biopsy. So you never do biopsy except you are the surgeon who will do the definitive surgery. We have to ask two questions: which part of the lesion should have a biopsy, and what is the safest route to that location? Types of biopsy: the most common biopsy we do is a core biopsy. This is under either CT or under ultrasound if it has too soft tissue. Fine needle of little importance. Open biopsy usually done in lesions that core biopsy are equivocal or the tissue or non-representative after 2 or 3 times core biopsy. So we have an open biopsy with the usual precautions with the incisional biopsy. Incisional biopsy done only for the benign tumors, not for malignant. So after assessment of the patient from history, examination, and investigation, how to proceed in a case of pathological fracture due to tumors? We have to ask ourselves, what is the underlying lesion? The underlying lesion, it's benign tumor, primary benign, or primary malignant, or metastatic. If the lesion is primary benign bone tumors, so we have different options. The criteria, first, is it's common in benign tumor, means the pathological fracture is more common in benign tumors than in malignant, mostly asymptomatic prior to the fractures. If symptoms usually present in the active or the aggressive lesions, as in EBC, as in giant cell tumor, while most of the latent or less active tumors, usually asymptomatic, usually the patient don't express pain prior to the fractures. While the example of the non-ossifying fibroma causing a pathological fracture. Usually this patient don't have any preceding symptoms before the injury. So the treatment depends mainly on the underlying lesion, not on the fracture. So we can start from non-operative treatment as the case like that case, non-ossifying fibroma. From the history, pain, there is no pain preceding the injury, and from the characters of the X-ray or even CT, so this patient can treat it conservative. So the first option is a conservative treatment. If the lesion especially is latent lesion, what is the indications of surgical fixation? For the lesion is aggressive or active. Active or aggressive lesions usually need surgical treatment. For the fracture itself, an acceptable deformity in the cast, open fracture or fracture non-union. This is the indication of surgical treatment of benign tumors. In benign tumors, surgical treatment includes usually is curettage of the lesion, extended curettage, with use of adjuvant and the use of the possible internal fixation, either intramedullary or extramedullary. The condition is extremely different in if the underlying lesion is primary malignant bone tumor. It's relatively rare, other than in comparison with the benign tumors, may occur prior to the treatment or even during the treatment or after treatment, usually as radiation, osteonecrosis in Ewing or lymphoma. So what we can deal with the patient with pathological fracture due to primary malignant bone tumors? The options are the following. First is accurate diagnosis, accurate staging of the lesion is very important. Our options are the following. First, if the patient, the lesion after biopsy is chemosensitive, as in usual in case on conventional osteosarcoma, we start with chemotherapy. After ending the cycles of chemotherapy, we will do a restaging again, starting from MRI and other usually PET scan, to see if this patient is chemosensitive or not. If the patient is chemosensitive and the lesion, the fracture saw good healing, and the lesion vascularity is decreased and the size is decreased and become well capsulated, so it's good responder for the chemotherapy, we can start for limb salvage. But if this lesion is chemo resistant, which is usually the case in 2/3 of the patient with pathological fracture, so we can do amputation. So our options is either a limb salvage or amputation, according to the sensitivity for the chemotherapy. So start with immobilization first, traction or external fixator or cast. We have to do staging of the lesion, proper staging, proper biopsy, either core biopsy or even open biopsy with the regular instructions. Start with the chemotherapy if the lesion is chemosensitive, and then assess. If the patient is chemosensitive, as we said before, so we can do wide resection, reconstruction. If the patient is chemo resistant, which is usually the case, we need to amputate. So in our strategy, there is no options for internal fixation in patient with primary malignant tumor. We start with staging biopsy, chemotherapy, resection, or versus amputation. There is no option for the internal fixation. So if the internal fixation was done in case of primary malignant tumor, it's a fatal mistake. Why? Because it leads to amputation of the patient. This is the least danger, or the more dangerous spread of the tumor, and even affects the patient's life. In case of the underlying lesion is a metastatic, our goals are different. Our goals is prevention of this osteopenia, mechanical support of the weakened of the fracture bone, pain relief, or decrease the length and the cost of hospitalization. Our aim usually is not to complete cure of the patient. Is usually palliative was most of the cases. Internal fixation as an intramedullary or extramedullary with or without cement augmentation is the standard care of pathological fracture, especially long bone. Whenever there is a pathological fracture in long bone, it's better to do intramedullary is better than extramedullary. Extramedullary as blade usually we used it for very articular fractures, and cement augmentation usually in most cases is very important. As we said before, biopsy, especially for the solitary lesion, is very important for the metastatic lesion. For metastatic lesions that has multiple lesions, we don't need for biopsy. Nails versus blade, as we said, nails is better than blade in long bones, and nails is better long nails than short nail. We don't use short nails. In that cases, we do use long nails with cement augmentation. Plates for very articular, we can use arthroplasty in a case of pathological fracture of the neck of the femur. Then other therapy as radiation or chemotherapy or bisphosphonate according to the primary lesion. This example of a long bone with a METS femur. So we did a long BFN with a cement augmentation. We can, in this case, we can't use short nail. We can't use retrograde nail, short one. We can't use plate. So it's better an intramedullary long with locking screws and with cement augmentation. Very important in healing with metastatic cancers that are hypervascular. There's a potential for risk of intraoperative bleeding, especially renal cell carcinoma and especially for thyroid lesion. They are hypervascular and may cause intraoperative bleeding. Usually in these cases, we need a preoperative angiographic embolization. Very important in management of the patient with METS is a prophylactic fixation for the impending fracture. We can use the known Merrill system that use the location, radiographic appearance, size, and pain. For the score less than 7, usually no surgery, we can start conservative treatment and follow up. If the score is more than 7, we need usually a prophylactic fixation. What is the complications of these pathological fractures? Usually loss of fixation is the most common complications owing to the bone quality, infection, delayed wound healing, and failure to heal. The prognosis after treatment, the bone may or may not heal. So the factors that affect whether the healing include the location of the lesion, extent of the bone destruction, tumor histopathology, type of the treatment, and the length of the patient survival. So the prognosis depends mainly on the underlying lesion. If benign, usually it's excellent. In malignant, if METS uniformly fatal or is median survival. Lung and kidney usually from 6 to 12 months. Breast and prostate, we know that this patient has a long survival up to 80 months or more than We see patients with breast and prostate cancer with more than 10 or even 20 years with good condition. Myeloma is median survival 3 to 5 years. Lymphoma, 60 or 80% survival at 5 years. Osteosarcoma, 70% survival at 5 years. This slide, I know that's not appearing very well, but can summarize what we see. The pathological fracture of long bone, the most important is the staging. To know it is primary, benign, or malignant, or it's metastatic. If it's primary benign, we can use, as we said, conservative treatment, or if aggressive lesion, we can use intralesional curettage with fixation. While the tumor is primary malignant, if it's low grade, we can do wide resection without chemotherapy. If it's high grade, we can use first chemotherapy. The patient that responded to the chemotherapy, we need wide resection with reconstruction, whatever biological or non-biological. While the patient that don't respond to chemotherapy, we need to amputation. While the case of METs, usually we need fixation with cement augmentation, and for later on adjunctive treatment as chemotherapy or reducer. Thank you.
Thank you so much, Professor Mahmoud Ibrahim, for this very comprehensive review about pathological fractures. Thank you so much, my friend.
Thank you, Dr. Mohamed.
I will
start to stop sharing.
Stop share, please. And we have some questions for you.
Stop sharing. Okay, done.
Thank you so much. First question, if I'm faced, this is for me, I have faced about 2 weeks ago, a young child with a pathological fracture on a bone cyst, simple bone cyst, but it was a huge cyst. I did a fixation of this fracture. Do you prefer to augment this fixation with bone cement or bone substitutes?
According to the age of the patient and according to underlying etiology. The more younger the patient, it's better to use biological as bone substitutes or so on. The more longer or the more age of the patient, we use cement. This is number one. Number two, the aggressiveness of the lesion. The lesion is more aggressive or active like ABC or giant cell. We can use the cement because the cement here we can use is an adjuvant, not just a space filling. Also, the location of the lesion. If the lesion was a diphyseal or simple metaphyseal, we can use biological. But the more the lesion near the articular or very articular, so the cement is more powerful to support the articular cells. Sometimes we can use combinations. If there is a very articular lesion near the articular surface and we do curettage, after doing the curettage, there is no subchondral bone, just the articular surface. If you use cement alone in this area, there is heat that lead to subsequent osteoarthritis. So we combine. We use a bone graft to support the articular surface, and we use bone cement with it.
Yeah. And what's your experience about the expandable prosthesis?
Expandable prosthesis is very important in reconstruction, especially in pediatric patients. But the limitations usually, like that in Egypt, sir, the financial issue. Yes, financial issue. So, yes, in pediatric patient, we can use it, but when the financial issue can be overcome.
So, what's the plan B for young patients with primary metastasis or malignancy? If I cannot got the expandable prosthesis.
Yes. According to the location. If the location is diphyseal, we can use something like Lazarov lengthening, but it's lengthy and multiple operations. Or we can use the rotation plasty. Rotation plasty is a very good option in that patient because they avoid to use high knee amputation, above knee amputation. Rotation plasty can use the foot and ankle as working as knee, and use below knee amputation. They are a good function. They usually no financial issue about that option, but it's better for them to use expandable prosthesis, but the limitation due to financial outcome.
Yes. And when do you decide to do prophylactic fixation in pathological fractures or impending pathological fractures?
Usually we have two issues. First issue, the underlying pathology is the most important. The underlying pathology, if it's malignant, we never do fixation. Primary malignant IE. And if it's primary benign, according to the situation, and usually intraoperative, the situation is intraoperative. After curettage and cement or bone graft, if I see that bone is weak, and usually the lesion extends to 2/3 of the circumference of the bone, and some authors recommend half the circumference of the bone, we do fixation. But in MEDS, we have a Merrill criteria. Merrill criteria is a good criteria, still valid till now. We can use the Merrill criteria. If it's less than 7 score, we don't use, but with follow-up, regular follow-up is very important because the size of the tumor may be progressive. And if it's more 7, it's better for prophylactic fixation because prophylactic fixation is better than to fix the fracture after the patient is fractured.
Yes, sir. We have 2 questions from our dear attendees. First question, is treatment of multiple osteoporotic fractures in leg is similar to treatment of kebab fracture?
What's meant by kebab fracture? I don't know.
I think he's meaning shish kebab.
Shish kebab, like osteogenesis imperfecta.
Osteogenesis imperfecta, I think so.
I think that's the question. What's meant? Multiple osteoporotic fractures, you mean in the same area?
I think so.
I don't think so. Osteoporotic fracture usually occur in adult or elderly, while this osteogenesis imperfecta in young patients, we can use shish kebab because this is having deformity. That's number 1. Number 2, you can use flexible fixation, but the healing power is very high. But elderly, we're facing the problem of we need more rigid fixation. That's first. Usually the patient has no deformity, and usually the healing has very low, the patient has a very low power of healing. So I think in these cases, we need to do a multiple or better to a hybrid fixation, intramedullary with extra.
Yes, sir. You hear me?
Yes, I hear you.
Yes. The second question is stress fracture of metatarsal bone considered pathological fracture?
No, of course. Pathological fracture is a different entity from stress fracture. Pathological fracture mean the bone is abnormal. Whatever the abnormality is infection, abnormality is tumor, abnormality is osteoporosis, and minimal trauma or trivial trauma came to the patient post fracture. It's called a pathological. Pathological mean the bone have pathology. Stress fracture, the bone is normal, but multiple repetitive stress. It's not a single trauma or large trauma. It's trivial trauma, but repetitive stresses that the bone can't withstand. And usually stress fracture seen with healing power. It's a small microfracture with healing, small microfracture with healing. Resist repetitive cycles, then occur stress fracture. Also, stress fractures have patient predilection, patient in the army, patient who do stresses that can't withstand, and though has specific locations as neck of the femur, as the tarsal, or second metatarsal.
Yes, sir. Dr. Srinivas, please, sir.
Excellent talk. Thank you very much, sir.
Thank you, Mr. Srinivas. Thank you, Dr.
I wanted to ask one question. For the pathological fractures, what is the commonest pathology in the benign, primary malignant, and secondary malignancy in Egypt?
According to the age, mostly in the pre-puberty in the children, ABC, we can see it's very frequent to cause pathological fractures. In adult or non-spine fibroma, by the way, non-spine fibroma is very common, and the usually patient have a trauma with no preceding symptoms, either non-spine fibroma or ABC. In elderly, MEDS or myeloma is very common. And elderly, after osteoporosis, by the way, and osteoporosis is the first common pathological fracture in elderly. Next, myeloma or MEDS. Primary malignant bone tumors is rare. Is the rare last entity to do pathological fractures because these types of patients have a lot of pain. So the pain makes them, the weight bearing and the activity are limited. So pathological fracture usually occur during treatment, during chemotherapy, or long after treatment with radiation.
Okay. Thank you.
Yes, sir. Professor Karthik, you have any comments, sir?
Oh, excellent talk. So it was.
Thank you, my Prof. Thank you.
We covered everything, all the key aspects. Thank you.
Thank you.
Thank you,
Thank
sir.
you.
Thank you, sir. Finally, we come to the end of this webinar and to the end of the Egyptian-Indian online orthopedic review course. Many thanks to our dear speakers from India, from Egypt, to our dear attendees. Many, many thanks to my friend, Dr. Srinivas, for his endless effort and great support to complete this course. Many thanks to OrthoTV. Of course, many thanks to the Egyptian Orthopedic Association, the Indian Orthopedic Association, Eva Pharma Company for sponsoring this course. I hope we will continue our cooperation and collaboration between these two great countries, Egypt and India. And of course, we will see you again in another cooperation with our dear Indian colleagues and dear Indian friends in the International HIP webinar, and coming more and more cooperation in the specialty days in shoulder, knee, elbow, forearm, wrist and hand, foot and ankle. I hope to last this cooperation forever. Many thanks to all of you, and see you next month, because we will start preparation for the SICOT, and I hope to see all of you in the SICO in Egypt after 10 days from now. Thank you so much, and have a very nice time. Thank you so much, sir. Thank you so much.
Thank you, our Prof. Thank you. Shukran.
Thank you, sir.
Thank you. Bye-bye.
Bye-bye, sir.